When you buy a brand new pair of running shoes, you're really paying for the midsole, right?
Hmm.
Like that thick, bouncy layer of foam sitting right between your foot and the pavement. It's engineered with one very specific, highly crucial job, which is to absorb shock.
Oh, absolutely. I mean, it is the ultimate biomechanical buffer because without that foam, every single step you take is just bone and joint and delicate tissue slamming directly into solid concrete.
Yeah, and anyone who has worn out a pair of sneakers knows exactly what that feels like.
Yeah.
When that foam finally compresses, when it deflates from hundreds of miles of use, you feel it instantly. Your knees start to ache. You get friction blisters. The simple act of moving becomes physically unbearable.
Right, and we just accept that reality for our feet without a second thought. We understand the engineering behind it.
Exactly. We
Yeah.
get the engineering. Yet, when we talk about that exact same biomechanical failure happening in a highly taboo area of the female body, suddenly the conversation just stops. It's wild.
Or, historically, the conversation gets diverted away from biomechanics entirely, and the medical response becomes incredibly drastic.
Which brings us to the core of our deep dive today. We are looking at a topic that, at first glance, might sound highly specific, perhaps even like a purely cosmetic gimmick to some. But it addresses a surprisingly common and functionally frustrating issue for you or someone you know.
Yes. We're asking, can labial filler actually help with chafing and severe exercise discomfort?
It's just such a fascinating intersection of aesthetic medicine, biomechanics, and women's health.
It really is. Our mission today is to step away from the taboo entirely and look strictly at the engineering of the human body. We've pulled from a diverse stack of sources for this, ranging from clinical guidelines by the British Association of Aesthetic Plastic Surgeons and the NHS to aesthetic clinic breakdowns, all the way to a raw Reddit AMA.
All right, so whether you are a dedicated cyclist, a marathon runner, or, simply someone fascinated by how modern medicine solves everyday problems, this is going to completely reframe how you view cosmetic injectables. Okay, so let's unpack this.
Let's do it.
Before we can understand how a syringe full of filler could possibly fix chafing on a spin bike, we really need to understand why the chafing is happening in the first place. What is the actual anatomy at play here?
So, to understand the friction, we have to look at the architecture of the vulva. And we need to focus specifically on two main structures. First, you have the labia majora. These are the outer hair-bearing lips, and they are composed largely of specialized fatty tissue.
Okay, the outer fatty layer.
Right. And then tucked inside those are the labia minora. These are the inner folds. And their biological makeup is entirely different. They are composed of highly sensitive mucosal tissue, which is incredibly delicate and richly supplied with nerve endings.
So mechanically speaking, those outer lips, the fatty labia majora, they aren't just there as a visual boundary, right? They actually have a physical job to do.
They are literal anatomical shock absorbers. Their primary functional purpose is to act as a protective cushion. They physically shield those delicate inner mucosal structures from the friction of walking, running, wearing tight gym clothes, or sexual intercourse.
But just like that running shoe foam we talked about earlier, the body's natural cushioning doesn't always last forever. So what causes that outer layer to wear down?
Well, it happens for a variety of compounding reasons. The natural aging process, for one, slowly breaks down collagen and elastin throughout the entire body, leading to a loss of structural integrity.
Which makes sense, yeah.
Then you have hormonal shifts. The massive drop in estrogen that occurs during perimenopause and menopause specifically causes that localized fatty tissue to atrophy or shrink. Plus, events like childbirth can physically stretch and permanently alter the capacity of that tissue to hold volume.
Okay, so aging, hormones, childbirth. But reading through the medical data, there's another trigger for this volume loss that feels incredibly relevant right now. The aesthetic medicine world is currently documenting a massive spike in what they're calling the Ozempic vulva.
Yes, and what's fascinating here is how interconnected our bodily systems are.
Yeah.
And how new medications reveal those connections. I mean, GLP-1 medications like Ozempic or Wegovy, they're leading to rapid systemic fat loss for millions of people.
Right, and the biological reality is that you cannot spot reduce fat.
Exactly. When the body drops weight that rapidly, it pulls fat from everywhere. That includes the deeply functional protective fat pads of the labia majora.
Man. So to put this in perspective, it's essentially like a helmet that has lost its inner foam padding. The hard structural shell might still be there, but without the thick, dense cushion, the delicate parts inside are just rattling around and getting battered with every single movement.
That is a perfect analogy. When that outer cushion deflates, clinicians refer to the resulting condition as exposure symptoms. The delicate inner labia are suddenly left entirely unprotected.
Oh, wow.
Because the outer lips have lost their volume, the inner lips drop below the boundary of the labia majora. They end up rubbing directly against tight gym clothes, or the nose of a bicycle seat, or honestly, even just the seams of regular underwear.
But wait, what if someone hasn't gone through menopause and they haven't lost a massive amount of weight? Like, are some people just built in a way that causes this friction naturally?
Absolutely. Clinical guidelines clearly state there is a massive natural variation in human anatomy. Some individuals simply have longer inner labia from puberty onward.
Okay, so it's just how they're anatomically built.
Right. The clinical data notes that inner labia measuring over 4 centimeters in length will very often protrude past the outer cushion, regardless of whether that outer cushion is fully inflated or deflated.
And what happens to that highly sensitive mucosal tissue when it's subjected to that constant daily friction?
Well, the mechanical friction literally wears away at the mucosal lining. The result is severe irritation and chronic dryness because the moisture-producing glands are being disrupted.
Ugh, that sounds awful.
It is. It leads to micro-tearing of the tissue and intense pain during any kind of repetitive exercise or sexual intimacy. It becomes a chronic, highly disruptive pain cycle.
That sounds absolutely agonizing. So logically, if a patient goes to their doctor complaining that their inner labia are exposed and chafing against their clothing, you would think the medical reflex would be to restore the cushion. Fix the padding in the helmet. That just makes sense.
That is the logical assumption, yes. But medical history tells a very different story. For decades, the standard medical response wasn't to restore the protective cushion. Instead, the go-to solution was to surgically cut away the exposed inner tissue.
Which brings us to the traditional surgical route. And honestly, reading the first-hand accounts of this procedure is just eye-opening. The surgery is called a labiaplasty or a labial reduction. And we have an incredibly raw, unfiltered Reddit AMA from a patient who went through this exact process.
Yes, and she was only 19 years old when she opted for the surgery.
Right.
The motivation behind her surgery is a crucial piece of this puzzle because it speaks to a much broader issue in women's healthcare. She initially went to her OBGYN simply asking if she was a candidate for the procedure because she was experiencing discomfort.
And her doctor's response was, she told her that she was one of 3 women she had ever seen with inner lips that long.
Which is just a devastating thing to hear from a medical professional at 19.
Seriously. She wrote that it made her feel like a complete freak, like this anatomical anomaly.
If we connect this to the bigger picture, it really highlights a deep systemic issue regarding how women's anatomical variations have been excessively medicalized. Societal pressure, which is largely driven by unrealistic imagery, pushes for a neater or more prepubescent look. And unfortunately, that pressure often filters directly into clinical interactions.
Even though it's completely normal. Right.
Entirely normal. The clinical consensus across the British Association of Aesthetic Plastic Surgeons is that vast variations in size and shape are perfectly natural. Yet patients are still made to feel defective.
So what does this all mean for the patient? She mentions in the AMA that if she'd known she was actually within the range of normal anatomy, she'd have never opted for the surgery in the first place.
Exactly.
But looking past the psychological toll for a second, did the surgery at least fix the physical chafing?
Well, it did solve the immediate mechanical problem. She admits the good outcome was that she no longer experienced chafing in tight clothing, and walking was no longer painful. Because the exposed tissue was gone, the friction stopped.
But the cost of solving it that way was massive.
The clinical reality is actually much harsher than the simplified nip-and-tuck narrative suggests. This Reddit patient deeply regrets the surgery. Her healing process was brutal.
Yeah, she mentioned enduring 6 months of severe pain during intimacy as the scar tissue tried to settle.
Right. And furthermore, she later learned from a different medical professional that because the structural integrity of the tissue is surgically altered, she now carries a risk of severe tearing if she ever chooses to go through natural childbirth.
Wow. So how long does the recovery for something like this actually take, according to the official guidelines?
The clinical data from institutions like the NHS and Spire Healthcare validate her experience entirely. A labiaplasty is not a minor cosmetic tweak. It is a highly sensitive surgical intervention. Patients require 1 to 2 full weeks off work just to manage the initial swelling and pain.
Just to manage the swelling.
Yeah, and beyond that, you're looking at 4 to 6 weeks of absolutely no exercise, no cycling, no running, and no sexual activity.
And there are permanent risks involved even if the healing goes perfectly, aren't there?
Indeed. Anytime you cut into highly innervated tissue, there is a risk of nerve damage, which can permanently alter or dull sensation. Beyond that, there is a recognized and highly distressing complication known as over-resection.
Over-resection. What happens during over-resection?
That occurs when a well-meaning surgeon removes too much of the inner tissue, trying to ensure it stays completely tucked away. Because that specific mucosal tissue contains the essential glands responsible for natural moisture and lubrication, cutting it away leaves the patient with chronic, lifelong dryness.
Wait, really? Lifelong?
Yes, and because the moisture is gone, it introduces a completely new type of painful friction that is incredibly difficult to treat.
Man, it feels like treating a stubbed toe by amputating the toe. I mean, if the root problem is a lack of protection, a failure of the body's shock absorbers, isn't there a less destructive way to stop the friction than putting patients through a painful, permanent surgical amputation of highly sensitive tissue?
This raises an important question, and it is exactly the paradigm shift that modern aesthetic gynecology is finally embracing. Instead of aggressively cutting away the exposed tissue, medicine is now looking at how to safely and simply restore the protective cushion around it.
Into the labial puff. Now, I have to admit, the name sounds like a late-night infomercial cosmetic gimmick.
Mm.
But functionally, looking at the biomechanics, it's a complete game changer. Clinics are now utilizing dermal fillers to reinflate the labia majora.
It is a highly effective biomechanical fix. However, we need to make a very crucial clinical distinction here based on the aesthetic dermatology data. If a patient walks into a clinic asking for an injectable to stop vaginal chafing, they cannot just accept any product off the shelf.
Right.
There is a massive fundamental difference between what the industry calls skin boosters and what are actually classified as fillers.
Break that down for us because the terminology in aesthetic medicine gets very confusing very fast.
It really does. Both categories are generally made of hyaluronic acid, commonly known as HA. But it's how those HA molecules are chemically engineered that dictates their function. Skin boosters, like a popular product called Profilo, use what is called non-cross-linked HA.
What does non-cross-linked actually look like?
Imagine tiny individual sponges floating freely in a liquid. When a doctor injects a skin booster, they inject it very shallowly right under the surface of the skin. Those free-floating sponges purely exist to draw in water and hydrate the tissue.
So they're just moisturizing from the inside out. They don't change the shape of anything.
Precisely. They do not add bulk or structural support. Now, they are fantastic for treating the paper-cut pain of menopausal dryness or restoring elasticity to thinning tissue.
Okay, good for hydration.
Exactly. But if your primary problem is biomechanical chafing against a rigid bicycle seat, a skin booster will do absolutely nothing to stop the physical friction.
So to stop the chafing, you need the heavy-duty architecture. You need fillers.
You need structural support. Fillers, such as a specialized product called Deserial Plus, utilize cross-linked HA. Instead of free-floating sponges, imagine those HA molecules have been chemically bonded together into a dense, durable, three-dimensional net. This creates a high-viscosity, thick gel.
And how is that actually applied to fix the chafing?
A medical professional injects these dense gels deep into the existing fatty tissue of the labia majora. The gel creates immediate, actual structural volume.
So by adding that volume, they physically push the deflated outer lips back together, which completely conceals the inner lips, hiding them away from the friction of your clothes.
Yes, exactly.
Here's where it gets really interesting. Mechanically, it's like restuffing a flat, lifeless pillow instead of throwing it away and buying a smaller pillowcase. You just put the padding back.
Spot on.
But pushing back on this, practically speaking, if someone is getting this filler specifically so they can go cycling or run marathons, aren't they literally sitting on and crushing that gel all day with their entire body weight? Why doesn't it just squish out of place like a crushed water balloon?
That is a brilliant question, and the answer lies in a concept called rheology, which is the study of how materials flow and deform under pressure.
Okay, rheology.
Right. These high-viscosity, cross-linked HA fillers are specifically engineered with specific rheological properties to integrate deeply into the surrounding tissue. They don't just sit in a pocket waiting to be displaced.
Oh, I see.
The chemical net of the filler meshes directly with the patient's existing fat cells. It effectively becomes one with the tissue, allowing it to absorb severe shock and weight without migrating.
So it legitimately acts like the integrated midsole foam of the running shoe.
It does. However, the environment it operates in dictates its lifespan.
Hmm.
Because this specific anatomical area is subjected to constant pressure, heavy movement, increased body heat, and severe friction, the body's natural metabolism breaks this filler down much faster than it would if the same gel were injected into a static area like your cheekbones.
So it's not a one-and-done solution.
No. The physical relief from chafing is immediate, and there is zero downtime. It is literally described as a lunchtime procedure where a patient can walk out and resume normal life, but it is strictly temporary. Depending on the patient's metabolism and activity level, the body will metabolize the HA away in anywhere from 6 to 18 months.
Gotcha. And digging into the clinical discussions, there is a bit of a medical debate hidden in the research about the materials being used for this.
Yeah.
Hyaluronic acid is incredibly popular for one major reason. It is 100% reversible.
Yes, reversibility is key for a lot of patients.
Right. If something goes wrong, or if the patient simply hates the feeling, a doctor can inject an enzyme called hyaluronidase, which breaks down the HA net and dissolves the filler completely in a matter of hours.
Reversibility is a massive safety net. But, as you noticed in the sources, some top plastic surgeons, such as Dr. Karen Leong from the American Society of Plastic Surgeons, refuse to use HA for labial puffing.
Yeah, why would a surgeon turn down the safest, most reversible option?
Because of how HA interacts with this specific tissue over time, Dr. Leong points out that in her clinical practice, she has seen documented issues with HA fillers causing granulomas.
Granulomas.
Yes. A granuloma is a hard inflammatory nodule that forms when the immune system tries to wall off a foreign substance. In an area constantly subjected to friction, a hard nodule is incredibly painful. Because of this risk, Dr. Leong prefers to use biostimulatory fillers, like calcium hydroxylapatite.
Okay, how does that differ from the HA gel?
Calcium hydroxylapatite doesn't just sit there acting as a cushion. It actively prompts the body's own cells to produce new collagen around the injection site, creating natural volume. The trade-off, however, is that it cannot be instantly dissolved with an enzyme if there is an issue.
Right, so it's a significant trade-off. Reversibility versus the risk of inflammatory nodules. But regardless of which synthetic filler a patient chooses, HA or biostimulatory, they are essentially signing up for a subscription model.
Pretty much, yeah.
They have to keep going back to the clinic every year or so to get their shock absorbers reinflated. Which leads us to the final and perhaps most compelling piece of the puzzle. What options exist for a patient who wants a permanent biological fix? If they are tired of scheduling appointments to get crushed synthetic filler re-injected, what's next?
This brings us to what might be the most fascinating science fiction-sounding procedure in the current medical literature: autologous fat grafting, which is more commonly known as a fat transfer.
Autologous meaning the material comes entirely from your own body.
Exactly. Instead of using a synthetic gel engineered in a laboratory, a specialized surgeon uses microliposuction to gently harvest a small amount of the patient's own fat. This is usually taken from areas where the fat is robust, like the abdomen or the inner thighs.
Okay.
The medical team then purifies this harvested fat in a centrifuge to isolate the healthiest, most viable cells and meticulously injects it into the labia majora.
But moving fat around the body is notoriously tricky, isn't it? If you relocate a fat cell, it doesn't always survive the trip.
That is the ultimate challenge of fat grafting. When you inject living fat into a new location, it arrives without a blood supply. It has to survive on whatever ambient nutrients are in the surrounding tissue until the body can grow new blood vessels into it, a biological process called angiogenesis.
Angiogenesis, okay.
Right. And because a significant portion of the transferred fat will inevitably die off and be safely absorbed by the body, usually about 20 to 30%, the surgeon has to deliberately over-inject the area during the procedure.
So, practically speaking, the patient wakes up looking a little more puffed than they bargained for.
Yes, the initial volume is intentionally exaggerated, and unlike synthetic fillers, there is a real surgical recovery period here. Patients will experience swelling and bruising for a couple of weeks, but the magic happens during the healing phase.
How so?
Whatever fat manages to establish a solid blood supply after the 3 to 6 month mark, that fat stays there permanently. It behaves just like the normal natural fat in that area, expanding and contracting with your overall body weight.
Okay, so it's essentially an intimate recycling program. You are harvesting the cushioning from a place you don't really want it, like your thighs, and relocating it to a place where it will permanently cure your exercise pain. That alone is amazing. But reading through the clinical studies on this, The volume restoration isn't even the best part of the procedure.
Not by a long shot. What is truly revolutionary here is the cellular biology of what is actually being transferred. A surgeon isn't just moving passive, inert blobs of fat. They are transferring what cellular biologists call the stromal vascular fraction.
What exactly is the stromal vascular fraction?
It is a deeply complex, rich mixture of cells found nestled within our fat tissue, and crucially, it includes an incredibly high concentration of mesenchymal stem cells.
Wait, stem cells. So it's not just sitting there taking up space, it's actively repairing the surrounding area. How does that actually work?
Mesenchymal stem cells are essentially the body's microscopic general contractors. When you inject this microfragmented, purified fat into a damaged area, those stem cells and their associated growth factors immediately go to work, assessing the damage and regenerating the surrounding tissue. They release signals that prompt the body to build new blood vessels and produce fresh collagen.
Oh, wow. So it's healing the tissue from the inside out.
The clinical outcomes are astounding. It actively thickens thinning aged skin. It restores natural hydration to parched mucosal tissue. And incredibly, it can actually soften and remodel old, painful scar tissue.
That's incredible.
Yeah, for instance, if a patient has tight, unyielding scars left over from tearing during childbirth or from an episiotomy, the stem cells can break down that rigid collagen and replace it with supple, healthy tissue.
That is wild. It transforms a mechanical cushion into a biological repair kit. The medical data even notes that this specific fat transfer technique is being used to successfully treat severe dermatological conditions like lichen sclerosis, which is an autoimmune condition that causes painful, fusing white plaques on the vulva. The stem cells from the fat transfer can literally push that condition into remission and restore healthy, pliable tissue.
It fundamentally changes the medical paradigm. The industry is finally moving away from treating a symptom by amputating sensitive tissue and moving toward treating the symptom by actively regenerating and supporting the body's own protective architecture.
So if you've been listening to this and realizing that the agonizing friction we've described sounds a lot like what you experience every time you get on a spin bike or go for a run, you need to know that the game has changed. We started today with a topic that is so often buried under layers of embarrassment, suffering in silence, and societal taboo. But when you strip away the stigma and look at the sheer biomechanics, it is simply an engineering problem. The medical field is finally realizing that the issue isn't that there is too much tissue to be cut away, it's that the protective padding has worn away. Reinsulating the body's natural shock absorbers, whether you opt for a quick, temporary hyaluronic acid filler or a permanent regenerative fat transfer, is a highly functional, deeply science-backed solution to a very real physical problem.
And if we connect this to the bigger picture, it leaves us with a truly provocative thought to mull over. We just spent this deep dive exploring how injecting your own microfragmented fat not only provides a permanent physical cushion, but utilizes stem cells to actively heal, remodel scars, and regenerate damaged tissue.
Right.
Well, if this regenerative fat grafting works so perfectly as a biological shock absorber in one of our most sensitive, friction-heavy anatomical areas, could this exact same technique eventually make synthetic medical implants obsolete for treating worn-out cartilage in our knees, our hips, and other heavily exercised joints? Maybe the future of repairing our body's shock absorbers isn't found in a laboratory or a titanium implant. Maybe it has been hiding inside our own fat cells all along.